Good to go. Okay. I'd like to welcome you all to the 2021 World Sepsis Day webinar. We're part of the National Sepsis Programme, and I am Martina Healy, who has been the National Clinical Lead for the last 3.5 years. So just a quick look through our programme for today. So I'm going to do a quick introduction of the National Sepsis Report for 2019. It's a summary of the actual report. 2020 data will be difficult to get hold of because, as we know, the pandemic wiped out a lot of our access to the hospital audits and so on. We're then going to hear from Professor Jerry Fitzpatrick from NCEC with an intro to the Adult Sepsis Guideline. And Celine Conroe, one of our ADONs, is going to give us an Adult Sepsis Management National Clinical Guideline update. Mary Bedding will then, another one of our sepsis ADONs, will talk about the adult sepsis management, the e-learning, and the introduction to the new adult sepsis form. And then I'm going to do a quick summary of the National Paediatric Sepsis Guidelines and our implementation plan. And then last of all, it's with great joy, I'm going to present you to our new clinical lead who will be taking over from today. So this is the 5th National Sepsis Outcome Report, which describes the burden of sepsis on the Irish healthcare system in terms of number of cases and associated mortality. This data, as we said, is from 2019. And I think it's important to look at how this differs from some of the data that we've produced already. So these are the main figures from the National Sepsis Report 2019. So there was an overall total number of cases of sepsis, septic shock in 2019 was 13,390. This gave us a crude mortality rate of 18.4%. And we also break down our sepsis group into adult non-maternity patients. And this group had an in-hospital mortality in the sepsis and septic shock group of 19.7%. We also have our specialty-based data, the maternal sepsis-associated mortality rate, which we're glad to report was 0 in this time frame, and the pediatric sepsis-associated hospital mortality rate, which was 3.7% in 2019. The group that I suppose we're most concerned about, and which we'll probably have a lot of emphasis on in the next few years, is the surgical sepsis-associated in-hospital mortality group. And the mortality rate for this group of patients was 24.5%, and the medical sepsis-associated in-hospital mortality rate was 18.7%. So what's important to note is really the trend. So the numbers in itself don't mean an awful lot. So it's important to compare them with the previous year, just to make sure that we're actually achieving what we're trying to achieve with our education and our e-learning. So what was interesting was the definition of sepsis and septic shock had actually changed in 2017. So a lot of the key comparatory figures, it was difficult to compare. But with 2018 in the adult non-maternity cohort, there was an 11.8% decrease in documented cases of sepsis and septic shock, with a 2.9% decrease in associated in-hospital mortality. Associated with that was a 5% increase in the average length of stay for this group of patients. In the actual sepsis group, there were 11,819 cases documented in 2019. Now, the definition of sepsis did change from earlier reports. So this was a 12.7% decrease when compared to 2018. So that was 11,819 versus 13,547. This gave us an in-hospital mortality rate of 18.1% and represents a 2.6% decrease in mortality over 2018. So of major importance is to benchmark this with international figures. The UK 20.3%, the USA 25%, Australia 19%, and globally 27%. So in septic shock, there was a 0.27 decrease when compared to 2018. The new definition of septic shock gave us an 11% decrease in mortality when compared with 2018. So in our pediatric group, the crude mortality rates remained at 3%. So in summary, the documented cases were up 114%, but the associated mortality was down 22.68%. And sepsis patients have a 5.2-fold increase in higher mortality over patients coded with infection and a 2-fold higher length of stay. So the recommendations we'll go through at the end of my talk, and maybe Michael might talk through these. And so I'd like to now present Professor Jerry Fitzpatrick, who's going to give us an introduction to the new adult sepsis guideline. Thank you.
Thank you, Martina. Thanks very much. And I'm delighted to be here today on World Sepsis Day 2021. And I thank the National Sepsis team for the invitation to make these remarks. And I hope you're all wearing a little bit of pink to remind people about World Sepsis Day. So today sees the publication of the National Clinical Guideline number 26 on sepsis management in adults, including maternity. Now, as you know, the development of national clinical guidelines is overseen by the National Clinical Effectiveness Committee, or NEC. And this is a ministerial committee set up in 2010 on foot of a key recommendation of the report of the Commission on Patient Safety and Quality Assurance. Its job is to provide strategic leadership for the National Clinical Effectiveness Agenda. With regard to national clinical guidelines, the role of NEC is to prioritise, to quality assure, and to recommend clinical guidelines to the Chief Medical Officer for endorsement by the Minister for Health. National clinical guidelines are quality assured and go through a rigorous methodological process of the highest international standard prior to their publication. And as such, they can be trusted to provide the most up-to-date recommendation and evidence to healthcare professionals and others. While NEC provides the governance and the oversight of these activities, it's important to acknowledge the wide range of experts and advisors who contribute to the process, and the important roles of partnership organisations such as HRB, CISR, and HICWA. Today, I would like to congratulate all involved in the development of the National Clinical Guideline on Sepsis Management in Adults. This has involved a considerable amount of work by many individuals. I want to acknowledge the contribution and commitment of the members of the Guideline Development Group, the Guideline Working Group, the National Sepsis Steering Committee, and the HSE National Sepsis Programme. Particular thanks are due to Dr. Vida Hamilton, who chaired the Guideline Development Group, Dr. Martina Healy, who's the National Clinical Lead for Sepsis, still, I think, and Dr. Fidelma Fitzpatrick, Chair of the National Sepsis Steering Committee. This new guideline is a testament to their leadership in advancing evidence-based care for patients with suspected sepsis. Thanks also to the staff of the Clinical Effectiveness Unit and the National Patient Safety Office for their ongoing commitment and exemplary service to NEC and to the patient safety agenda. And finally, I thank all the members of the National Clinical Effectiveness Committee and our partnership organisations for their ongoing support. And in doing so, I would make particular mention of the patient representatives on that committee, whose commitment and contributions have been invaluable over the years. The first National Clinical Guideline on Sepsis Management was launched at the end of 2014. Following its implementation, there was a demonstrable reduction in mortality from sepsis in Ireland, as outlined by Martina. Our expectation is that following the implementation of this new guideline and the other important initiatives being announced today, we will see significant further reduction in mortality from sepsis over the coming years. Thank you.
Thank you, Professor Fitzpatrick. And we'd like to introduce Saline Conroy, who's now going to give us an update on the new adult sepsis guideline. Can you find yours on there?
There. Thanks, Martina. Thanks, everybody, and it's with great pleasure that I am here to introduce and to launch the National Clinical Guideline for Sepsis Management for adults and maternity patients. So the purpose of this guideline is to implement the Surviving Sepsis campaign guideline in Ireland for use in the Irish context. The wording of the recommendations haven't changed, except for where exception units of measurement are different. We're very grateful as a sepsis programme to the Surviving Sepsis campaign for allowing us to adapt their guideline for use in Ireland. So the guideline doesn't replace clinical judgment, and in certain circumstances, people may decide not to use the guideline, but to do so with a consultation with senior clinicians. It applies to all adult patients, including pregnant women and women in the postnatal period, up to 42 days in the acute hospital sector. You'll notice that all maternity-related information is highlighted using purple text. It doesn't apply to paediatric patients, but Dr. Martina Healy will introduce the National Implementation Plan for paediatric patients a bit later on. The target users for the guideline are all healthcare professionals involved in the care of adult and maternity patients with sepsis or suspicion of sepsis working in the acute hospital sector in the Republic of Ireland. The Department of Health can also use it to support the implementation and audit of the guideline, and the HSC can use it to provide appropriate structured support and adequate resources to operationalise the guideline. In addition to that, the hospital group leadership and hospital teams can use it to support sepsis quality improvement, to facilitate implementation and audit of the guideline, and to facilitate and monitor required changes that arise from outliers that are identified. The Pre-Hospital Emergency Care Council can also use it to inform their clinical practice guidelines across the ambulance services, and the public can use it for information purposes. So we include implementation points throughout the guideline to guide people on how to operationalise the recommendations from the Surviving Sepsis campaign within the Irish healthcare setting. The implementation points are primarily for the pre and post critical care setting. The Guideline Development Group itself was chaired by Dr. Vida Hamilton, and membership nominations were sought from a variety of contexts across the clinical setting. These involved clinical practice, education, administration, research methodology, and 2 people representing patients and public. So what's different? Well, Martina already mentioned that the sepsis definition changed in 2016. So sepsis is now a life-threatening organ dysfunction caused by a dysregulated host response to infection. The World Health Organization also produced a definition for maternal sepsis in 2017. And again, it's noted to be a life-threatening condition defined as organ dysfunction resulting from infection during pregnancy, childbirth, post-abortion, or postpartum period. What's the difference between sepsis 2 and sepsis 3? Well, there's 3 differences, primarily 3 differences. The first is that sepsis 2 was a SIRS-based definition, and it was oversensitive, so it produced more sepsis than actually could be called sepsis. It also failed to recognise patients with life-threatening organ dysfunction because of an infection, but that didn't actually have a SIRS response. And it wasn't specific either, because SIRS could be caused by non-infective reasons. It's important, though, to note that SIRS can still help you to identify infective cases. So, we won't throw it out. It just isn't used now to define sepsis. Septic shock is a subset of sepsis with circulatory and cellular metabolic dysfunction associated with a higher risk of mortality. This is part of the new sepsis definition. The definition task force defined this as a requirement for vasopressors or inotropes to maintain mean arterial pressure. and lactate greater than 2 millimoles despite adequate fluid resuscitation. However, the rationale for this definition was to identify a cohort of patients with a mortality risk greater than 40%, and this is for the purpose of international comparison. But patients with a vasopressor requirement and normal lactate post-resuscitation have a mortality risk of greater than 30% anyway. So for this purpose and for facilitating the identification of septic shock in Ireland, we took a pragmatic approach, and we acknowledge that the sepsis definition task force allowed us to do this. We've said that septic shock in Ireland is a vasopressor or inotrope necessity following adequate fluid resuscitation, because those people need to be got to critical care more quickly. So there's a little bit of confusion, sepsis 2, sepsis 3, sepsis 6. Just to point out that sepsis 6 is actually the name given to the bundle of care to treat sepsis. And we know it as Take 3, Give 3. So it was developed in the UK, and there's also a sepsis 6 plus 1 in Ireland. The plus 1 relates to fetal well-being for the pregnant woman. So the main difference in the updated sepsis guideline is the 3-hour and 6-hour bundles that we were used to have now been combined into a single 1-hour bundle. This is with the explicit intention of beginning resuscitation and management immediately, in particular for people who arrive to us and are very clinically apparent sepsis shock, septic shock or sepsis. When they arrive, well then they should have the sepsis 6 administered within 1 hour. If they are not clinically apparent, then we carry out some tests and investigations if infection is part of their diagnosis. And when the results come back, we have then 1 hour to deliver the sepsis 6 bundle. We call this time 0. So to help you to operationalize the new and updated guideline, we have produced some clinical decision support tools for operationalizing this at clinical level. They have been updated, all the tools have been updated in line with the National Clinical Guideline, and they include the adult sepsis form, which we're going to show you later, the sepsis predisposition and recognition for maternity inpatients form, and a fluid resuscitation algorithm for adults with sepsis. Thanks very much.
Thank you, Celine, for that introduction to the new adult sepsis guidelines. So I'd like to present Mary Bedding, who is one of our sepsis aid-ons in the RCSI hospital group. And Mary is going to talk about the large amount of work that's been done on education and training, which will appear on the HSE Land website in the next, in the future. Thank you, Mary.
Thank you, Martina. Okay, as Martina says, I'm Mary Bedding and I'm one of the sepsis aid-ons, but I work for the RCSI hospitals and I'm also a member of the National Sepsis team. And I'm going to briefly walk you through the new HSE Land Introduction to Sepsis Management for adults, including maternity, which is available on HSE Land from today. So firstly, why did we need the update? Well, in 2016, as Celine and Martina have mentioned, there were new sepsis 3 definitions, which were adopted in Ireland. So obviously, we needed to incorporate those into our sepsis e-learning. There was also a growing need for maternal information and learning, which is clearly addressed in the updated version of the HSE Land e-learning. And also some of the sepsis resources that we were using, including some of the clinical decision support tools and the adult sepsis forms, were outdated. So there was clearly a need to update the programme. So the audience and the aim and the The target audience for this e-learning program is all staff. It's the same as the previous program, really, and it's all staff that are involved in the recognition, management, and treatment of patients in acute care settings. This includes nurses, midwives, doctors, and health and social care professionals. And the aim of the program is to help the user to effectively recognize and manage sepsis in the adult population in an acute care setting in accordance with the recommendations of the National Clinical Guideline number 26, sepsis management for adults, including maternity. The scope then includes non-pregnant and pregnant adults, so that's patients over the age 16. Pregnant adults includes women from conception and up to 42 days post delivery or post birth, and that includes miscarriage and abortion. The learning outcomes at the end of the program are that we would hope the learners would be able to recognize patients that require sepsis screening, those in high-risk groups or those that have deteriorated due to infection, and those with signs of sepsis. We also hope that the learners will know how and when to use the sepsis form to aid recognition and treatment, and identify when to escalate for a medical review. They will also should be able to manage patients with the 1-hour sepsis bundle, the Sepsis 6 or Sepsis 6+1, as Saline alluded to earlier, and also how to review and respond to a patient's response to treatment. Being able to define sepsis and septic shock are also very important, and also that they can document those as well, and know when to escalate a patient to critical care. As I said, this program covers the recognition and management of maternal sepsis. All of the maternity-specific information is highlighted either in purple text or in purple boxes, similar to the National Clinical Guideline. The maternity content is actually optional. However, it should be remembered that any pregnant woman or post-birth woman can be an inpatient in an acute care setting outside of maternity. So it might be well worth everybody completing these sections as well. The design is very similar to the iNews and iMuse. It's an animation. It has its own color palette and characters. It's interactive with knowledge checks and scenarios along the way to keep the learners engaged. And the topics, there are 5 topics. 4 of them have an introduction of what will be covered. Then the information is imparted along with the interactive knowledge checks. And then there's a summary of every topic afterwards. And I suppose as a team involved in the update, we were very cognizant of the other national clinical guidelines, including iNews and iMuse, clinical handover, etc. And we made sure that we used the recommendations from those in our e-learning. So as I said, there are 5 topics. Topic 1 is what is sepsis? And that not only goes through the definition of sepsis, but it illustrates the pathophysiology of sepsis and identifies those that are at risk. Topic 2 then is how to recognize sepsis. And this goes through the signs and symptoms of infection, SIRS, organ dysfunction, and septic shock. It also informs the learner on when to initiate the sepsis form and the escalation to a medical review. And in line with the iNews National Clinical Guideline, it emphasizes the role of clinical judgment and in escalating a patient for medical review. Topic 3 is the initial review and sepsis management. And this walks the learner through the pathway for sepsis management from the alert to the management with Sepsis 6, 1-hour treatment bundle, the take 3, give 3, and the diagnosis of sepsis. Topic 4 is the ongoing review and management. And this covers when senior medical personnel should be involved and when escalation to critical care is required. And it also covers the ongoing daily review. Topic 5 then is the clinical scenarios, and there are 2 clinical scenarios. The first scenario is compulsory for all learners. It is a high-risk patient. This is a patient who is 10 days post-chemotherapy, who is at risk of neutropenia, who has fallen and has a fractured hip, but he's been cared for in an orthopedic ward outside of an oncology unit, and he has deteriorated due to an infection. The second scenario, which I've stated previously, is optional, is the maternity scenario, which relates to a woman who is one day post-delivery who has deteriorated due to an infection. Within the scenarios then, you'll see that there's a toolbox at the bottom of each scenario, and it contains a number of icons which relate to the iNews, iMuse, sepsis forms, sepsis management algorithms, etc. And you'll see that as you work your way through the scenarios, these icons will change to an orange color if there's additional information to update the learners that they can use. When it comes to each scenario, there are clinical decision points which are similar to the iNews program, and the learner has to select the most competent response out of the three that they are given. If they choose the wrong one, then they are given a rationale for why it's incorrect, and they're then redirected back to the clinical decision point again to select the correct answer. Only once they've chosen the correct answer will they be able to progress through their scenario and finish the scenario. At the very end then, once one of the scenarios or both of the scenarios have been completed, there's a summary of the whole program. This directs the participants where to find sepsis resources. There's also an extended learning section which gives additional reading and the references. So how do you complete the program? Well, it'll take about an hour to complete, but it can, if you leave, if you can't do it all in one sitting, if you come away from it, you can actually return to it and it will resume where you left off. So it should only take about an hour to complete. So it can be completed in multiple sittings. You have to visit at least 80% of the slides to complete, and the high-risk patient scenario must be completed successfully in order to get to the end. And at the very end then, the certificate isn't emailed out to you as they used to. It'll actually be found in the My Certificates section on the HSE land. And the program itself is awarded 1.5 NMBI CEUs or 2 RCSI CPDs. And the program, unlike the previous program, is valid for 3 years and will have to be updated once that 3 years has gone by. So that's the sepsis e-learning. Now I'm going to move on to the new sepsis, the updated sepsis form for adults. I'll also touch on the maternity form, which has had one slight amendment, and I'll just mention the paediatric form, which is coming in very soon. So the new adult sepsis form has been redesigned in response to feedback from users, so that all of the information that they are required to complete is on one page. That's the first page there on the left-hand side. But the supporting information, which made the previous form rather text-heavy, is now on the reverse. So page 1 is just, I suppose, to say that the form will replace the ED, the inpatient, and the combined forms that were on the website previously. And this form can be used for inpatients and emergency department patients. So that will reduce the printing costs for hospitals, as there's no need to print 2 different versions of the form. On the form, you'll see a number of light bulbs illustrated, and these are where you can get additional supporting information for the user, and that's on the reverse side of the form. The form guides the users on when they need to initiate the form, and again emphasizes clinical judgment, as Celine talked about previously. Suspicion of infection prompts the user of the form to ascertain if the patients require sepsis screening, and then they're asked if the patients fall into one of the 3 high-risk categories. If they do, then they need to go on to get the sepsis 6. However, it will also guide if you don't need to use the form. So if they have an infection but they don't fall into any one of those high-risk groups. Okay, so then the section A is the medical review. The A clinician is asked to state the site of infection. They're also asked to state which high-risk group that they fall into. If the patient doesn't have an infection, the form can be terminated. Similarly, if there's an end-of-life care plan, then the form can be, and it's not appropriate for the patient to have sepsis 6, again, the form can be discontinued. If the patient has an infection and they fall into one of the high-risk groups, or there's clinical judgment that requires the patient to be sepsis screened, then the time 0 should be recorded and they should move into the sepsis 6 bundle. The sepsis 6 bundle just needs the times of initiated recorded. And then after that, once the sepsis 6 has been given and post sepsis 6 bundle administration, the doctors will come back to review the tests and investigations that have been carried out, as well as the signs and symptoms that the patient has. And here, this is where they will diagnose whether the patient has sepsis or they don't have sepsis. And if they have sepsis, it guides them to look out for the signs of septic shock. And if they do have septic shock, then it reminds them to get a consultation from critical care. And finally, or as we move down almost to the end of the form, then there is a clinical handover piece where if the patient is handed, or if midstream of the sepsis 6 or before the diagnosis, the patient is handed over to another clinician, then this section will be filled out. And then the grey area down at the bottom will be filled out by the doctor, and it says practitioner, so AMPs or AMPs can also use this form as well. So as I said, on the reverse of the form is where the guidance is to help if there's any of the additional information is required. So that's sepsis, the adult sepsis form. With the maternity form then, just to say that there is one amendment to it. So you will see on the website that the maternity sepsis form is amended. And just in line with obstetricians and feedback from obstetricians and midwives, and in line with maternity guidelines, that in the A section of the ISBAR, the SIRS criteria of a temperature has reverted back to 38 degrees. And then the paediatric sepsis form, just to say that there is work in progress. This is being trialled nationally at the moment and should be available very soon. And finally, I'd just like to thank, or we would like to thank the Clinical Design and Innovation who provided the funding for the e-learning update. And a huge thank to all the members of the sepsis team and Kira Hughes, our previous program manager, for their input in both of the e-learning and the sepsis form update. And if you have any feedback, we would, we do appreciate the feedback that people can give us. So in terms of the e-learning or the sepsis forms, then you can contact myself or any of the other members of the team, and you'll find our details on the sepsis web pages. So thank you.
So I just need my paediatric slides. This was followed by the establishment of the program with the sepsis program manager and the sepsis lead. 6 sepsis ADONs were appointed at that time, and lovely, thank you. And of note, there was no pediatric sepsis ADON. So when I took over the lead job from Vita Hamilton in 2018, we had a very clear program of what we wanted to achieve. Number 1 on our list was the introduction of pediatric sepsis guidelines, an implementation program and e-learning program for pediatrics, and most especially of all, the funding for a pediatric sepsis ADON. So luckily, and it's with great pleasure, we now introduce the pediatric sepsis guidelines. So in February 2020, which was really well timed, the Surviving Sepsis campaign, which had never produced any agreed international pediatric sepsis guidelines, produced the first set, and they were published in Intensive Care Medicine in February 2020. So following on from that, the National Paediatric Sepsis Programme convened a multidisciplinary paediatric sepsis working group. And after a lot of meetings and discussion, the group recommended adopting the Surviving Sepsis Guideline, international guideline for the management of septic shock and sepsis-associated organ dysfunction in children. And to just give you an idea of how difficult it was to get international agreement and recognition for these sepsis guidelines, this is the group of people who met for a period of 3 to 4 years to actually agree these guidelines. So the international panel was assisted by various methodological experts and was split into 6 groups. And they basically looked at the recognition and management of infection, the hemodynamics and resuscitation in pediatrics, recommendations, reventilation, endocrine and metabolic therapies, and adjunctive therapies. So I'm not going to go through all the pediatric guidelines, but I'm going to pick out the big ticket items that we felt were really important in that pediatric sepsis differs from adult sepsis. So for the purposes of the guidelines, the definition of septic shock in children is severe infection leading to cardiovascular dysfunction, including hypotension, which is late in children, and the need for treatment with a vasoactive medication or impaired perfusion, and sepsis-associated organ dysfunction in children as severe infection leading to cardiovascular and/or non-cardiovascular organ dysfunction. So septic shock in children was defined as a subset with cardiovascular dysfunction. And you needed to have greater than 2 or based systemic inflammatory response syndrome criteria. You needed to have a confirmation of or suspected invasive infection with cardiovascular dysfunction and/or acute respiratory distress syndrome. So there are differences in the guidelines on the management of children with sepsis. Fluids and sepsis has a whole seminar in itself. But one of the issues with sepsis in children is that the majority of sepsis in children, particularly the mortality, is associated with third world countries where intensive care is not available. So the use of fluid boluses in children caused a lot of controversy, and the sepsis guidelines had to agree with both first world and third world guidelines. And for that reason, there was a very careful look at the bolusing of fluid in children with sepsis. And this guideline, and we agree, recommends that in units with access to intensive care, 40 to 60 ml per kilogram boluses can be given per bolus over the first hour. However, with no intensive care backup, it is recommended that limiting the amount of fluid boluses with care should be considered, but obviously each individual patient is different. This panel from the Surviving Sepsis group suggested crystalloid rather than albumin and a balanced buffer solution rather than 0.9% saline. And they recommended against using gelatins or starch in children. Another big ticket item was to take blood cultures, but don't delay treatment if you cannot obtain them. So the 1 hour treatment time, which the adult guys have now adapted, was more controversial in children. And one of these reasons, it was extended up to 3 hours without shock. There is a relationship between the administration of antibiotics and outcome in severe sepsis. But some pooled data demonstrated it was unlikely that the hour alone made a difference. So the extension to the 3 hour window was a welcome relief for those working in areas where there were associated penalties for not reaching the hour window or for overextending the hour window. And it'll hopefully remove some of the gaming associated with this target. So there still is a 1 hour window for septic shock, but when children with a query, this was extended to 3 hours, a time window. I'll discuss that on our algorithm at the end. Hypotension in children, its definition is age-related, as we know. So it was very difficult for this group to be very dogmatic about hypotension in children, but they did agree with some specific numbers. So it is age-related, and a systolic pressure of less than 50 millimeters of mercury in children aged less than 12 months, extended to less than 60 in children 1 to 5 years, and then less than 70 millimeters of mercury in children greater than 5 years. They also agreed that prolonged capillary refill time is an important physiological parameter in children and should be used. And if it was extended greater than 3 seconds, that this was a red flag. Use broad spectrum antibiotics, but narrow when the pathogens are available. And again, you may not have those in the first hour window. So every hospital has its own antibiotic policies, and these should be followed locally. If no pathogen is identified, we recommend narrowing or stopping empiric antimicrobial therapy according to clinical presentation, site of infection, host factors, and adequacy of clinical improvement. And it's important to discontinue antibiotics if there's no requirement for them. The other big ticket item was the use of intensive care in vasoactive management with inotropes. They were acknowledged as weak recommendations, and one of the issues really was the access to intensive care. So we're lucky here in Ireland and elsewhere in Europe, whereby we have readily access to intensive care, to inotropes, and to ventilation if required. So a number of recommendations were given: use adrenaline rather than dopamine for septic shock, but these were generally based on the panel's summation of weak evidence. So I think if you need an inotrope, use whatever is available and use it early if at all possible. There are further suggested small ticket issues on steroid management, nutrition, and blood products, and which will be available if you read the sepsis guidelines. So I think what they did produce was a really good initial resuscitation algorithm for children, which I think everybody should have in their hospitals and in their EDs and on the wards. And it very clearly goes through the 1 hour, extending to the 3 hour window if that's required. And it has a very nice algorithm for IVIO access, collect your blood cultures, start antibiotics, and then extending to sepsis and septic shock to commence the 1 hour window for fluid boluses and for starting inotropes. I think this is very well done, and I think it's something that we would probably advocate for having on our website with the sepsis guidelines. So following on from the introduction of the sepsis guidelines, we then had to move on to have these accepted by NCEC so that they would be available on the website and also available on an e-learning program. So the sepsis program convened a multidisciplinary pediatric sepsis working group, and these recommended the adoption of the Surviving Sepsis Campaign international guidelines for children. And we included all those involved in clinical practice, education, administration, research methodology, and persons representing the patients and of particular reference to the public. And we obtained permission from the Surviving Sepsis group to actually use their guidelines and implement them locally. And they were adopted within the acute pediatric healthcare setting in Ireland. So we have we have produced a national implementation plan, and it contains 77 statements on the early management and resuscitation of children and the resuscitation of children with both septic shock and sepsis or associated organ dysfunction. We also have implementation points for clinicians in the management of pediatric sepsis in the Irish healthcare setting. I think we have to remember that children don't just present to the tertiary pediatric hospitals all across the country, they present to adult ED. These guidelines are particularly important. I think the algorithms and the sepsis forum I'm going to show you now is really helpful for people to be A, reassured they're doing the right thing, and B, make them think of sepsis. Incorporation into the National Implementation Programme is a clinical decision support tool, which is our sepsis forum, and that's aimed at providing guidance for clinicians to both recognise and treat sepsis, and often to outrule sepsis. So lots of children present to ED, and it can be difficult to differentiate between the child with an infection and those actually progressing to sepsis and septic shock. So the front page is used for the recognition and screening for sepsis, to both rule in and rule out sepsis as a diagnosis. And the back page is the treatment, reassessment, and referral of these patients once they've presented. So the National Implementation Programme was widely disseminated for consultation, and we got considerable feedback over and up to January 2021. And with special thanks to Mark Peters, who was actually the co-chair of the Surviving Paediatric Sepsis Programme. He reviewed it and they were very happy to sign it off. The National Implementation Programme was clinically approved by the CCO Forum in August 2021. So it will accompany the National Clinical Guideline for Sepsis, number 26, and ensure a unified national approach to sepsis, starting from the age of, it excludes neonates up to and including all adults patients. So the next steps really are the implementation of the Surviving Sepsis recommendations. So we've actually worked long and hard to produce an education program for pediatrics, which will be available online and will be available for people to use locally. So we've developed a PowerPoint lecture set on pediatric sepsis, which will have an accompanying video, so you can actually use the video, or you can adapt the slides to your own local area, but use the PowerPoint. So it'll be available for all sites of care for children in the coming months, and will be launched with a e-learning module on HSE Live, which has been secured, and this will be accessible hopefully in the end of 2021 and the beginning of 2022. So to optimize sepsis recognition and treatment, the hospital group sepsis add-ons and the national sepsis team will liaise with each site to help support the setting up of a local sepsis committee aimed specifically at pediatric sepsis. Doesn't have to be a separate sepsis committee in non-pediatric hospitals, but in any hospital receiving children into their ED or into their hospital, we would recommend that there is a sepsis link to the adult sepsis committee, and that they should look at audits and perform feedback on, as well as doing adult sepsis care, they should also do pediatric sepsis care. And all pediatric hospitals and acute hospitals with pediatric units are advised to have a sepsis committee whose role is to guide the implementation of the guidelines and the implementation plan. And we and the sepsis team would be happy to take calls or to work with local committees to try and establish this. So as you can see from the poster behind me, we've worked long and hard we started with 0, so we have worked long and hard to produce local posters, which are available if people want to order them. We have pediatric sepsis leaflets available, and there are 2 sepsis videos which we would recommend. One is a short TikTok version of, I think, 1 minute per video, and the other is a longer video on pediatric sepsis. And these are available online. And I knew I'd actually got somewhere when one of my colleagues, a cardiologist, actually asked the words, had seen the posters because they were all over our hospital in Crumlin. Could this be sepsis? So the surgeons also kept, would ask, could this be sepsis? So it is all about education, reminding, and putting the posters and the leaflets out there and making the information available, not just to our clinical colleagues, but in particular to the public. I think one of the things that comes up frequently when we go out to meet the public is that they feel that the emphasis online and on the radio and TV, often they feel that we could do more to actually emphasize these, could this be sepsis, particularly to people who are caring for elderly or children who are more likely to develop sepsis, or the adults who are previously well who unexpectedly develop sepsis, so that they can ask the question, could this be sepsis? And I think on Sepsis Awareness Day, a public awareness campaign is something that we will and could do more to remind the public. I think the public work really well with information that's given to them. And we have recently managed to, I think Dublin Fire Brigade and the ambulance service are also going to have an awareness campaign on their vehicles. So I think we need to work on that, and that would be one of our future aspirations. So current program activity and achievements. So we have got confirmation from NCEG to publish the updated guidelines for adults. We have drafted and have accepted the Paediatric Sepsis Management Guidelines and the implementation plan. The education and awareness campaign for pediatric sepsis has now been updated and is ongoing. The learning module, thanks to Mary Bedding and Nuala, our sepsis aid-on, and Céline Conroy, this will now be available online. Unfortunately, we weren't allowed to have a sepsis summit this year, so for next year, that would be the plan. I think things to work on would be a sepsis awareness campaign for the GPs and the community. We will be launching the sepsis leaflet tool and obviously the 2020 report. So it's with great pleasure that I would like to introduce our new clinical sepsis lead, starting from today. So Dr. Michael O'Dwyer is currently a consultant in St. Vincent Hospital. He is an adult intensivist and anaesthetist, and he's been there since 2017 and is currently the head of department. So Michael has had an interest in sepsis for a long time, and actually completed a PhD in sepsis at TCD and St. James's whilst he was a trainee there. He moved from the Royal London Hospital to St. Vincent's, and I'd like now to introduce Michael, so he might give us an idea on what his goals would be for. And just before Michael takes to the podium, could I actually extend some thanks to some people? So I would particularly like to thank the sepsis aid-ons. So Karen, Ronan, Céline, Mary, Nuala, Sinead, and Kira Hughes, who was our program manager. So I would like to thank them for their work. It was a pleasure working with you, and it was. I'd like to wish you all the best for the future. So I'd like to introduce Michael O'Dwyer. Thank you.
Thanks very much, Martina, for that. It's also news to me that I'm starting today, so thanks for letting me know. Thanks for the introduction. You know, I've had an interest in this for many years. I've did my PhD in the mid-2000s on sepsis. And then since then in my professional life, I work with these patients every day, so I'm heavily invested in this space. And it's great then to come here and to listen to the huge amount of work that's been going on in the pediatric guidelines and the adult guidelines and the e-learning package, and particularly over a time period that's had a lot of additional stresses to get anything done that's not in a COVID type space. But this is perhaps an opportune time, given that COVID really is an epidemic of sepsis, but uniquely with a single organism causing it. But it shouldn't lose sight of that at the end of the day, what we're seeing over the last year and a half really is sepsis, and it should be very much in the public mind. The work that we've talked about here centers around really hospital-based diagnostics and management of septic patients, and by necessity, this requires repetition year after year to build a familiarity within healthcare, so that sepsis never goes unrecognized, and that when it's recognized, it's treated in a consistent and predictable fashion and to the highest international standards. And I look forward to continuing this process during my tenure. And as mentioned, the other key element alongside diagnosis and management is prevention. And a successful prevention campaign needs to be targeted towards first responders, towards GPs, and most importantly, towards the public. So a vision for this program would be understanding that sepsis it will still occur, it's not going to go away, but that when a person gets sick, particularly an at-risk person, that they are aware enough to ask, could this be sepsis? And that a family member would potentially ask, could this be sepsis? When they present to their GP, that same question will be asked. And when they get to hospital, they'll receive a consistent and predictable treatment to the best international standards. And that hopefully we can drive the mortality rate down even further than we've seen today. Thanks very much.
I'd like to thank all the presenters, and I'd like to thank Dr. Stephen Staff for allowing us to run this webinar today. So I'd like to formally close the session. And remember, be sepsis aware and always ask the question, could this be sepsis? Thank you.